For the past 3 years, we've lived with the SARS-2 coronavirus and the COVID-19 pandemic. The story of the impact of the pandemic on our lives, how we work, play, study, live, and more could fill volumes. The question for today, however, is where do we stand with regard to the pandemic, and what can we expect moving forward, as you see? Our guest speaker, Dr. Edward Linn, is a trustee of the Chicago Medical Society and co-chair of its COVID-19 task force. In this capacity, he has produced and participated in a number of highly regarded webinars designed to bring the members of society up to date on the issue, and as such is highly qualified to provide answers to our question of the day. In addition, he is currently a member of the Village of Skokie Board of Health, where he serves as chair and is active in the Medical Reserve Corps. Dr. Linn is currently involved in a variety of other COVID-19 related educational activities, including the IVAC Illinois Vaccination Against COVID-19 Initiative, where he serves as a member of the educational faculty and on the planning committee, and also at the University of Chicago's educational outreach programs. Prior to the onset of the pandemic, Dr. Linn had a distinguished career as an academic physician. He graduated from the University of Chicago Pritzker School of Medicine and completed his training in obstetrics and gynecology at Michael Reese Hospital. He has served as the chair of obstetrics and gynecology at Rush North Shore Medical Center and Advocate Lutheran General Hospital. In addition, he is a professor emeritus and former interim chair of the Department of OBGYN at Rush University Medical Center and the Rush Medical College. The doctor has served as both the chairperson of the Department of OBGYN at Cook County Health System and associate professor of obstetrics and gynecology at Northwestern University Feinberg School of Medicine. Dr. Linn has contributed to the OBGYN scientific literature and has extensively lectured locally and nationally on a wide variety of women's health topics, with focus on hormone replacement, contraceptive modalities, and infectious diseases. He has been the principal and co-principal investigator on several important research grants and has served on community service organizations and journal editorial boards. Dr. Linn is a resident of Evanston. Please join me in welcoming Dr. Edward Linn.
Yeah. Well, thank you, Dr. Jolene, for that introduction. If my mom was still living, she would believe it. I'm very honored to be here. I was very impressed the last time I visited your group. Unfortunately, when Dr. Jolene asked me, boy, it was like last year, to put together a talk, and we scheduled it far in advance, I assumed this was going to be a very distant historical talk. I'll tell you that today is a interesting anniversary. I don't know if you are aware of this, but it was exactly 3 years ago today that the first case of COVID was diagnosed in Illinois. I'd like to say that we don't diagnose it anymore, but we do. So let me just go through this with you. And by the way, if you're curious how an OBGYN got involved in this, I'll try to explain a little bit later, but let's just say that one great under-vaccinated group of women are pregnant women, and they are major at risk for significant problems when they are infected. But also, my background, I was a viral immunologist coming out of college and had actually done research in RNA viruses and made vaccines back in the late 60s. I never thought I would use that skill ever again, but it's interesting how circular life could be. So we're talking about the coronavirus, and the technical name is SARS-CoV-2, severe acute respiratory syndrome, CoV-2. And this is a schematic, an artist's rendition of what the viral particle, the virion, looks like. And I just want to draw your attention to those red projections. By now, you probably should know what they are. These are the spike proteins. And so this has been a target of all the vaccine development. It's these little projections that the virus will attach to cells. And I'll get into a little bit more in a moment. To give you an idea, coronaviruses are not new. And we first had a case reported in 2002 of the SARS-CoV the first infection called acute respiratory syndrome. And there were approximately 8,000 cases from 17 countries, and there were 744 deaths. Now, this created a big panic amongst the infectious disease world because they were afraid that we would have a worldwide pandemic. And it was this virus that precipitated the discovery of the method of making RNA-based vaccines. We're using messenger RNA segments, little gene chips, to program cells to produce various antigens. And I'll get into a little more detail in a moment. So, and that was first done at the University of Pennsylvania. So when people were claiming that the current mRNA vaccines were very new, the technology went back over a decade. But the infection dissipated, so they never made the vaccine. And then we had the Middle Eastern Respiratory Syndrome, or MERS. You may remember about this because this was actually a byproduct of the various military excursions that were going on at that time. And soldiers were bringing back this infection. And again, there was a fear that it would be spreading amongst the general public. It never occurred. There were approximately 860 deaths. And now we have the SARS-CoV-2, or COVID-19 for short, first reported in 2019. And we know that it's been a worldwide pandemic and still ongoing with a vengeance, for instance, in China. I'm not going to talk about the Chinese experience in much detail to say to you that the people of China, unfortunately, their government made a decision to vaccinate with a totally ineffective vaccine. The Sinovac vaccine, and we learned about that because they sold it to India, and India had the same problem. It didn't work. And they refused to use any other vaccine that was developed in the West. And they kept the virus in check by very draconian, strict isolation measures, which was killing their economy. So they ended up letting everything go. And now it's a huge epidemic right now. So this is the weekly trends in the number of COVID-19 cases in the United States that was reported by the CDC. And if you look all the way to the left on this slide, you'll see that goes back to January 29th of 2020. And you can follow it across, and we had peaks. And the biggest peak was the one that occurred right after Christmas in 2021 into 2022. And that was the Delta variant. You may remember that. And this was scary because of so many people in the United States getting infected. Fortunately, we have not seen that type of infection subsequently. We've had our peaks, and then they've come down. I should also tell you that it was, if you look at this graph, you'll see that these are the cases reported in Illinois look very similar. The order of magnitude is different, but the shape is very similar. Now, if you look at deaths, you'll see the majority of deaths were occurring early in the infection. So the original strain, the native strain, sometimes called the Wuhan strain, was infectious, but very deadly. And part of the problem was that we, as the medical community, didn't know what to do. And actually, we made mistakes. We had classic definitions when people came in with pneumonia and difficulty breathing. Often they were put on respirators as a routine. And we learned that respirators actually made the injury to the lungs, combined with the virus, worse. And it created a greater inflammatory response. And so places like the University of Chicago and Rush, I was at Rush at the time. I was the interim chair of the Department of OBGYN at that time. And we learned that we had to do alternative things. And they did some miraculous things. And where it used to be a death sentence, back in this time, if you had COVID and you were admitted to an intensive care unit, you had greater than a 50% chance of dying. I'll probably say that at Rush, 90% of the people were discharged. But they changed their approach. And Rush was like the epicenter of infectious disease at that time in the city of Chicago. The hospital was literally built for that purpose with contracts with the U.S. government. And they were able to convert the new buildings into intensive care units very rapidly. So when we go and we see another big peak that occurred during that Delta, we became very nervous. But Delta was very relatively quickly replaced by other variants. And these new variants actually are more infectious, but less deadly. So we kind of caught a little bit of a break. But also, we were then vaccinating. So what did we learn? Science and discovery have been rapid and well communicated amongst physicians and scientists. I've never seen more research coming out on any topic as quickly in my entire career. So every day there's something new, a new publication, and more data and more data and more data. However, the communication to the public has been poor. So there's tremendous confusion. I'm going to leave you with one thought as we move forward. Remember, we're in the internet world. And just as, you know, we were children, we played a game with a telephone game where you sat in a circle and you transmitted a message, and at the end, it was always different than when it started off. But think of that as 1,000 times increased order of magnitude. There's disinformation and misinformation. Now, disinformation, as I learned in studying the etymology, is purposeful misinformation. Why would anyone do that? In the United States, we have what we call the dirty dozen. There's 12 physicians, one based out of Illinois, who practiced in Schaumburg, Illinois. Fortunately, this person does not practice, and I'm not going to mention their name because I don't need another lawsuit. And another doctor in California who've been very prominent in misinformation. And yet, why would someone lie and actually say things that are totally untrue and unsupportive scientific? Well, there's big money in it because these people sell books and therapies and vitamins and all kinds of things. Millions and millions of dollars of revenue. And then there's misinformation, and that's just incorrect things that get misunderstood. And sometimes our media will misinterpret things. And for those you may remember, the last time I visited here, we talked about how to understand scientific principles, and I started teaching it to the media because they would not necessarily understand some of these things. So we're battling that problem right now. So number one, COVID is not influenza. Yes, you may get a flu-like syndrome because most respiratory viruses give you a flu-like syndrome because flu is a respiratory virus. So you cough, sore throat, runny nose. They all have this. But it's a coronavirus and it behaves differently. We now are faced with another variant that you probably have heard the media talk about this, Omicron, or as some people like to say, Omicron. I go back with the Greek pronunciation because that's what I learned in college when I had to learn the alphabet as part of fraternity hazing. And some people are saying we should call it SARS-3 because it's really different. And I'm going to point that out in a moment. We also know that we're capable of this infection, of repeated infections, even in vaccinated, and based on immune escape and viral changes, meaning every variant seems to become transmitted because it's mutated in such a way that the standard immune system that protects you may not catch up with this virus as efficiently. That's what the virus is doing. This is natural selection, but at a pace like we've never seen. and the virus changes. And we also know now that COVID has multiple mechanisms of disease. Most people have minimal symptoms. 10% will develop what we call hypoxemia, difficulty breathing or oxygenating. And now it's probably even less with these new variants. About 3% became critically ill, but this is usually associated with either older age, male gender. Yes, guys, we are the weaker sex. Just ask your insurance agent when they sell you a policy. And I'm also going to throw in there the people who are critically ill, who are less than 60 years of age, usually have some sort of inborn immunologic deficiency. We also know that, I'm talking about antibodies. That's one immune mechanism we have. We have two immune mechanisms in our body. Antibodies, which are proteins that are being made to latch on and kind of immobilize the virus so our immune system could clear it. And we have cellular immunity. These are lymphocyte-based immunity, which attacks the invader in a different way. And in people over the age of 70, we tend to have a different response. It's muted, but also we have differences in a type of interferon, which is a chemical that the body uses to defend itself. So immune deficiency or immune compromise and age are the things that are disadvantageous when you're trying to fight this virus. So this is a complicated picture, but I like the artwork. And so in the center, at the top here, and I don't know if I could use a pointer. Do you see the little arrow here?
Yes.
Good. So here's your virus. Here's these proteins that I mentioned, these spike proteins, and here's that little shred of RNA. Remember, RNA is a little messenger that the body uses to make DNA, or to actually it goes back and forth from the DNA in our nucleus, and this codes for proteins, codes for enzymes. It's the building block for our whole system. And when these, I lost my little cursor here again. Oh, well. When these enter the cell, they attach to an ACE receptor. Interesting, the ACE receptor also codes for our blood pressure. Who knew? But it attaches to the ACE receptor, and that's how it gets into the cell. And the goal of a virus is to make more virus. That's all it does. It just replicates inside the cell. So every time someone gets infected, the cell kicks out millions of viruses. When someone has an infection, their whole body is kicking out billions of viruses. It doesn't take much to imagine that errors occur, and that's how we get these variants. Now, once it gets out into the body, our immune system is going to recognize it. These little Y-shaped blue structures are antibodies. So the body makes antibodies against the virus, but also all these cells, the T helper cell, the cytotoxic T cell. I actually did research and characterized a protein we call lymphotoxin. That was my first foray into formal science. And these are killer cells. So that the two systems work together. The signs and symptoms that I mentioned before are very pedestrian. In 2 to 14 days after exposure, if you have symptoms, some people don't have any or they ignore them. I have an allergic history. I wake up every morning and I'm congested and I sneeze sometimes and I got a runny nose and I'm always running for the COVID test. You can burn through them, but often it's systemic. I never had COVID, knock on, that I know of. And, but believe me, I've had the symptoms, but it's fever, cough, and tiredness, which are the constellation. By the way, that sounds like influenza. We've just been through respiratory syncytial virus that little kids get and older adults. It's the grandkids sicken their grandparents. And And in the beginning, one of the cornerstones of this infection was the loss of taste and smell. And so that's how people kind of knew they had it. But if you look at the list to your right, there's a whole host of symptoms that you could be developing. So we don't have anything that's specific that says, this is COVID. Here's where I'm concerned, though. And this is what's being forgotten. You know, when I hear people say, it's only a cold, I should get it and get it over with. Not a good idea. Not a good idea because, and I put in red the areas that tend to be the most devastating. And we know now that you can have serious heart problems related to the infection. And by the way, this persists months after the infection. It's not just during the acute phase. I'll show you some more data in a moment. If you have cancer, you're at greater risk and susceptibility. If you have pulmonary problems, if you're a cigarette smoker and you have chronic obstructive pulmonary disease, or God forbid, if you have inherited cystic fibrosis or pulmonary hypertension, which is a cardiovascular problem, you can be very, very sick from COVID infection, as well as all these other common problems. The other big problem are the people who have solid organ transplants who are on anti-rejection drugs. These people get sick, but they get sick in a different way. They may persist. I mean, you hear stories of people who have transplants who get infected and they remain infected for months. They can't clear the infection. And actually, some of the theories are that they're the greatest source of variants because they have so many replications of the virus that are happening every day. Pregnancy, which I didn't put in red, but it should be for me, this is a high-risk condition. Any pregnant woman who gets COVID stands a significantly increased risk of ending up in the hospital or dead. There's also an effect on the fetus, and mainly with preterm birth. Give you an idea. Back when Delta, when I showed you that big peak that we had, at the Apprentice Hospital, the largest OB service in the state of Illinois, and they had like 11,000 to 12,000 deliveries a year. 25% of their OB beds were occupied by patients who had COVID at that time. Those people get really sick. And I mentioned to you about weak immune systems. The good news with HIV, with people that have AIDS, is that if their disease is well controlled, they're just like you and me. But if they're uncontrolled, they haven't been treated, they become very susceptible. And some medications make us more susceptible. So what happens that we get concerned about is this long COVID syndrome, which appears to occur in about 10% of the infections, even mild ones. People get a sore throat, they get a positive test, they stay home for 5 days, they're feeling great. And then they complain they're tired all the time, or they're got a chronic cough for weeks. There's very wide variability in this long COVID. It involves a variety of organs throughout the body. It doesn't have to just simply be your respiratory system. It's difficult to define. It also includes psychosomatic symptoms because people from anxiety. And it's very difficult to distinguish from a post-critical illness syndrome. Example, many people get a bad upper respiratory infection and they end up hacking and coughing for months. Sometimes they have to go on inhalers because they just have this chronic reactive airway syndrome, we called it. But we need a definition. We don't have it yet. Some institutions have set up special clinics for access to care for patients. Northwestern has one, but it's hard to find, hard to get into. We have to get community physicians involved so their patients may have access to the latest science. And we need to develop appropriate therapeutic modalities. We don't fully understand what long COVID means yet, and it's a hot area of research right now. This gives you an idea. Again, don't try to understand it because it's a little complicated fully, but just look at the top and you see all these different symptoms that you may get. And that's been attributed to what they call superantigens. So these are actually complexes of the antibodies and our immune system. So again, it's a type of a chronic inflammatory problem. Our body's still fighting and maybe overreacting. This is definitely the case with certain conditions due to autoimmunity. Does everyone know what an autoimmune disease is? I mean, rheumatoid arthritis is an autoimmune disease. Lupus is an autoimmune disease. These are types of diseases where our own body's immune system appears to be joining the enemy. So we're overreacting, so to speak. And that's what we think may be a trigger for some of these things. And then there's also viral persistence. We now know, for instance, that in the gut, in the intestine, this virus may live on beyond when you feel sick. So where are we today? Well, unlike MERS and SARS, we have over 1 million deaths from COVID. Okay? And I'm talking about in the United States. We're still having 300 deaths a week. Actually, we exceeded a couple of weeks ago 400 again. So when certain highly regarded politicians mumble that COVID's over, I don't know how they define over. Okay, we're in the midst of an Omicron surge right now, this variant and all of its subvariants. We have COVID fatigue. The medical community is tired of this. People are tired of it. Some people now have abandoned any sort of good judgment and are exposing themselves on a daily basis to something they may regret. And that's where we have this relaxation of mitigation strategies, and not driven by science, but by public opinion. A very sad bit of research was done in the Boston area. It was published a few months ago, where they looked at the reopening of schools. And they compared schools where they required masking for the kids. This is this past fall. That dirty word, masking. You know, 4-letter word in Florida. Dirty word. And they compared those to schools where the masks were not required. Guess what? Significant amount of disease in the unmasked schools, not in the masked schools. It works, but people are saying masks are evil, and you know they interfere with many different things. I had to take mine off now, and I try to be selective about it because I don't think you could hear me. But the good news is we have a decrease in case fatality rates and ICU admissions. So I pulled this up from last week. I didn't do it yesterday because I already had the slide set sent in. They publish this once a week. And I'll just kind of walk you through this. Oh, I'm sorry. Jumped the gun. So if you look at hospitalizations, way on the right of this middle graph, you see we're dipping down, okay, which is good. A couple of weeks ago, hospitalizations went up. We had a little blip, okay? Our deaths are going down. Unfortunately, our vaccinations administered is way down. Emergency room visits peaked up a little bit. A lot of that was because people were coming in wondering if they had flu. You know, people were scared. But our hospital bed use is down, and that's really where the government is focused now. So when you see all these, we're like in Illinois, I think we're still in the mid group of risk of acquiring. They're basing that on being hospitalized, not of getting the infection. Now, the big problem with all of this data, it's so unreliably underreported. And why would that be the case? People aren't getting tested anymore. They're doing their home testing. When you do a home test and you have a conversation with your physician, it's not reported anywhere, so we can't be counted. We don't know how many true cases are out there. We just know the ones that go to a commercial laboratory, like they show up in a hospital, or if your doctor sends it to a laboratory, then it's reported. So therefore, the government, in its wisdom, said, public health officials said, we got to look at hospital admissions because that's where we understand. And that's our greatest threat. Okay, to our society. But we really don't know how infected your community is. However, we have a new technology, and that's wastewater surveillance. Has anyone heard about this? There's a few hands. So basically, what someone figured out, some smart scientists, if you go to the sewer system where they're collecting wastewater for the purification plants, you can measure how much virus is there. And so they figured that gives us an idea. And roughly, it gives us like a 2-week window, because usually if you see a rising in the wastewater, it takes about 2 weeks before you start seeing the cases. Because it takes a while for these infected people to get out there and infect other people. And by the way, COVID virus is still one of the most infectious diseases we know. Like it's much more infectious than influenza. So like one person who's infected with influenza may infect 3 other people. In the case of COVID, you're talking about maybe 20 other people with these new variants. It's right up there like with chickenpox. Okay, and these little red blips, by the way, shows an increase at the time this particular screenshot that I took. But it appears that it may be coming down again. So we have this for the entire United States. It's being done a lot in the Northeast and being done in the Midwest. It varies by what state you're in. So where did all these variants come, as I mentioned? And it's basically 3 different ways that we can look at the variants. One is we call replication errors. The virus is, remember these codes are being copied inside the cell, and occasionally they get a little mixed up. It's like a typo. And I'm very good at that, so I understand it. And so that can create a new genetic variant. There's also RNA editing. In other words, how the cell handles it. So where proteins are being synthesized, remember, the main proteins that are being synthesized in an infected cell are other virus. Okay? And then we have genetic recombination. Now, this is near and dear to me because that was my high school science project. When I was at Niles West High School, I called it sex and bacteria. Because at that time was a very new concept, but I showed that with E. coli bacteria, you can get 2 different strains and they can transfer genetic information back and forth, and then it recombines. Guess what? That's what we're seeing with COVID now. Sometimes now it's called the Kraken virus. Has anyone heard that one in the media reported? Because it's a recombinant of 2 different Omicron variants to create even a more virulent variant. But if Omicron is so benign, as I mentioned, why should we care? But it's not a cold for everyone. Remember, it may have the symptoms of a cold, but it may have long-term effects. So I just wanted to give you an idea, and please, this is even complicated for most of us to understand in the medical community. Way over here on the left, we start off with the Wuhan. This was the original strain. And then there's cousins, the beta, the delta, the alpha. These are all these variants we've had in the past. But way over here, we're not talking what we're dealing with. As I said before, it's so far removed from the original strain that we're calling this sometimes SARS-3. Okay? And the BA5 was the game changer. And we had BA5 for months. Matter of fact, we were all relieved because that's what the new bivalent booster is. It was a combination of the BA1 and the BA5, 2 different strains we made a vaccine against. And from BA5, or its cousin, we're now dealing with where the arrow is, the XBB and XBB1. But it's very different from the original strain. So this complex slide, and I don't expect you to get into it, this is stuff that we read. Okay, I look at this, weekly. Gives you a rough idea of what we're contending with. give you an idea, and I'm going to move over here. Here's BA5 during Christmas in the United States. This is US data. Whereas a few months before, like around Labor Day, that's all we were talking about. And then we have BQ 1.1, BQ1, and now the XBB is growing. That's the Kraken. That's the recombinant one that has everyone concerned. And we really didn't know what was going to be happening. And we were anticipating right about now, big problem, especially after the holidays when everyone affects each other. And, everyone who's traveling, actually, most of the people I know who've gotten COVID, I can almost, have a winning bet that they've just got off an airplane a week ago when they traveled somewhere. It shows you just how filthy airports are. But we were scared because of what's going on in New York. And this gives an idea, as I said, if you look and just look at that BA5, that golden line, it's going down, but that XBB 1.5 is staying up. And they had a major problem in New York and the other New England states with this variant, and we were waiting for it to come west. And we expected here, but we're still waiting to see what the effect is. The good news is it looks like we're doing okay. And now a lot of experts are taking a deep breath and saying, well, we may be out of this mess for a variety of reasons. To me, the most important thing I'm going to tell you today, okay, and I don't want any hands raised because I don't want to embarrass anyone, but I'm looking at a group of my peers. I'm 73. If you have not received your bivalent booster, you're taking a huge risk. So that's my message. It's our best and most important strategy. Now, even though the bivalent booster wasn't targeted towards the XBB, it appears to be very effective, and I'm going to show you some data about that. But what we know in general about these vaccines, despite what's going on in the political arena, they're safe, they're well tested, and they're very effective. And it's helped prevent severe illness and hospitalization and death, and I'm going to prove that point in a moment. And it does appear to help against long COVID, and that's really the point. Okay? Now, myocarditis is an inflammation of the heart. In young males especially, we're talking about adolescents and young adults, many vaccines can precipitate myocarditis. It's almost an autoimmune phenomenon that the antibodies start to attack the heart muscle. But what's forgotten is that infection creates myocarditis at a much greater rate. And there's a difference. The myocarditis related to the vaccine, it seems to be very mild and self-limiting. The myocarditis from the infection can be deadly. And so if you're afraid of getting myocarditis from a vaccine, if I tell young males, then lock yourself up somewhere, hermetically sealed room, because if you get the infection, you have more to fear. And that sometimes is forgotten. The disease is worse than the treatment or the prevention, if you will. So here's where we are. These are all the vaccines that we have currently in the United States. All right. And I don't want to get into necessarily all the details here, but we have the RNA vaccines, which is your Moderna and your Pfizer BioNTech. There's now a second group of vaccines that really we don't use a lot of here, and that's what we call the viral vector vaccines. In other words, what they've done is they've gotten a non-replicating weak virus. It's usually an adenovirus, which is an upper respiratory infection virus, but it's not replicating. And they just use the virus to carry the genetic information into the cell. Okay? The ones you may hear of in Britain and Europe, the very popular vaccine was made from AstraZeneca, the drug manufacturer. We don't have that vaccine in this country. We have the other European vaccine here that was developed by Janssen, which is part of Johnson & Johnson. That's the J&J vaccine. It was actually very excited about that because it was a single injection. Okay. But it, for a variety of complex reasons, especially in my world, we don't use that vaccine in young reproductive age women because there's a rare complication where they may start developing a very strange coagulation disorder. It's not that different from the drug heparin. People get heparin for anticoagulation. It can actually cause a kind of a paradoxical effect because the effect on platelets, those cells that aggregate, and this vaccine triggered it in a certain age population. Now, I mentioned to you about the whole virus vaccines. We don't have any of these in our country, and specifically the Sinovac, which doesn't work. But we do have a protein subunit vaccine. It's a little different design, and that's the Novavax, which originally was developed in China too, but it just came on the scene. It's very recently been approved in the United States, and it's used in certain situations, mainly for people that don't want to take the mRNA vaccines because they believe that it causes mutation in the DNA, or they're fearful of it because they got on some website. You know, my two biggest problems in my career, and Dr. Google and Dr. Yahoo, you spend a lot of time talking why they're wrong. All right, so these are the rates of COVID cases, and this goes back to April of, the beginning of this past year, 2022, in people aged 12 and over. And the black line are unvaccinated. And so we're talking about the number of cases per 100,000 population. And just see the curve. And again, this peak occurred, in the summer. But if you were vaccinated without the updated booster, because we didn't have the updated booster, you just had your regular 2 initial vaccines and then your booster dose, depending on your age, 3 or 4. And you'll see this big difference in a number of cases. So this vaccine is protecting you from getting infected. We're not even talking about the severity of the illness. Now we came out with the bivalent boosters. Forget the comparison with the blue line. It means nothing. You can see it's even further diminished. And even though it looks small on this graph, it's still a big difference statistically between the people who were infected. So this was like the next phase of boosting, if you will. More importantly is deaths. And this is really the take-home message. There are no vaccines developed for upper respiratory infections that completely prevent you from getting the infection. Same thing with your flu vaccine. You may get the flu, but it's going to be a heck of a lot milder than if you weren't vaccinated. But more importantly, the chances of keeping you out of an intensive care unit or keeping you out of a mortuary is the effect we're looking at. And again, you can even see where that small little green line over there, all the way to your right, it's even further diminishing. That's the bivalent booster, because we only had it for a short period of time. It's another way of looking at it. And people age 12 and older who are vaccinated with an updated bivalent booster, okay, they have a 14.9 times reduced risk of dying from COVID. Okay, and this was based on cases in September. And a 3.2 reduction in testing positive for COVID. So it does keep you from getting infected compared to being unvaccinated. Now, this is a whole health slide. Okay. This is what I like to show medical students at 7 o'clock in the morning to wake them up and then test them on it. And really what it's showing is at least 1 dose of vaccine in the left column. They completed the primary series in the right column, and they had the booster all the way to the right. The middle column is primary, booster is all the way. And we look at the bottom, there's little differences there, the number of people that have received these vaccines. Okay. Here's what I want to point you to. I want to point you to the 50 to 59. It's kind of beige, the green, the pink, and then this, I don't know what color that is, purple, mauve, I don't know. These are the vaccination rates that we had. People got their first one dose. Then fewer got their second doses and their booster, the original booster. But look how bad we're doing with the bivalent booster. We're doing horrible. We're not even over 20% nationally. This is the city of Chicago, and we have a high vaccination rate compared to other cities and states in the United States. We're less than 20% of the people who receive their vaccinations have received that bivalent booster in the United States. It's irrational. We can't understand it. They've already been vaccinated. These aren't the anti-vaxxers who refuse vaccine. And we think there's multiple reasons for it. And we're struggling with it because they're better off than being unvaccinated, but our immunity from the vaccines wanes. It's not a lifetime immunity like you get when you get like a chickenpox vaccine or a measles vaccine. Now, another way of looking at this, and we're talking about unvaccinated adults, and we're talking about a period of time from June of 21 to March of 2022. These are the number of deaths that could have been prevented if these people received vaccines. It's very sobering. We lost a lot of people simply because they chose not to be vaccinated. Now, this is the other reason why I'm so concerned. This is a study that came out a few months ago, and this came from the VA. And they're looking at like 104,000 people. That's an enormous study. And because COVID is so popular, we can do these gigantic studies in a relatively short period of time. And I just want to draw your attention to these lines here. This is what we call a relative risk scale. I'm not going to get into the statistics. I talked about it when I was here last. For most people, relative risk means having your in-laws show up uninvited. But what it's showing is every time you get infected, okay, your chances of getting one of these complications increases. And this is dramatic. So if you had your third time of getting COVID, your chance of being hospitalized is way out there. And anything to the right of this line means it's statistically significant. Okay? Means it's real. Cardiovascular disease is what's scaring a lot of people. We now know that if a person had COVID, within the next 18 months, they're at much greater risk of having a heart attack. I bet you didn't know that. Now, one of my dear collaborators, my co-chair on the COVID task force, he's younger than me. He looks more fit than me. A brilliant doctor, takes care of himself. He had a big time MI a month and a half ago. And it wasn't that he had atherosclerosis, because when they did his angiogram, all his vessels were clear except for one. They call it the anterior descending. And if there's any doctors in the audience, the anterior descending we call the widowmaker. But he had a soft plaque, which was due to platelet aggregation, and they were able to open it. So he's doing fine right now, thank God. And the only thing we can figure out is it could have been that COVID that he had. So this should be the discussion amongst your friends and relatives, that you don't want to catch it. Yes, you get immunity when you catch it, And if you have the vaccine plus immunity, you have what we call this hybrid immunity, okay, which is super immunity, but there may be a price to pay. And we're just learning to understand it. You look at all these complications are increased once you've had COVID. And again, this is a complicated slide, and we're running near the end, but we have a big issue between public perception and what's reality. Okay, and a lot of people just feel that they don't need to get the vaccine anymore. And we know that the reality is a little bit different. And one big problem we've had is that remember when they approved these vaccines, they're under EUA, emergency use authorization, meaning there's enough science that the FDA will approve it, but we're still not convinced. There needs to be more science, more research done. When they came out with these vaccines, especially the booster, you may recall there was a bit of a kerfuffle amongst the experts because when they approved the bivalent booster, they did it based on laboratory and based on animal model, not based on human trial. But the booster was really the same vaccine, but a little different code than the original. So the FDA said, go ahead and release it. And initially, and you can look at the dates, but initially the studies that were done with the pseudovirus, which was a research model. And that's what they did it. And then we had more time, and now we have more viral live virus. And when you looked at the pseudovirus, no difference, small difference, no difference. And let some experts, like Dr. Paul Offit, who's a pediatrician, infectious disease guru, a vaccinologist, saying there's no reason to get the booster. Stay with the old one. Now, Paul never said don't get the booster. He said we don't need the new booster. But people have misquoted him as saying he said you don't need a booster. But the new booster came out. And now we know through better science that yes, it does work. And that's in the laboratory. This gives you an idea of the magnitude of difference. So the blue line is placebo. The gold line is vaccination with the new booster. Huge difference in prevention of incidence, accumulative incidence of disease. This just is hot off the press. This is a study done from Israel. Israel's health system has been a rich source of scientific information because they have such great records and they can look at this population very closely. Again, the pink line is, is showing cumulative hazard or risk of getting infected. It goes up over time. Yet the blue line, which is the booster line, the bivalent mRNA booster, shows that you can keep the infection down really low numbers. And again, this translates an 81% reduction in COVID hospitalizations in Israel and 86% reduction in deaths. This is a US data. And again, it's hard to maybe appreciate or understand. But if you look during all those big peaks that we talked about, back last year, if you were vaccinated, you were here. This is the newer variant. We had this peak go up in the fall, unvaccinated people again. But down here is that new bivalent booster. This is a big difference statistically. This is a Kaiser Family Foundation survey. They do wonderful surveys out on the West Coast. 44% said they don't need to think they need it. 37% said they don't think they benefit from it. 36% say they've been too busy or have not had time to get it. Okay, I understand. And I appreciate it because some people, and I can tell you, I kind of had the same mindset. I had to plan my vaccination because I said, I need to have 2 days because I don't know how I'm going to feel the next day. So I don't want to be doing anything critical. And I can tell you, in all honesty, every injection I received, from the first to my bivalent booster, I had a fever. My wife's walking around, that's nothing. I don't feel anything. And I'm laying on my back popping Tylenol. So, but I knew my immune system was working. So that really got me excited. 17% of adults have not gotten the updated booster because they say it's not done because they're waiting to see if the cases increase in their area. Yeah. It's like I don't want to put my seatbelt on. We'll wait and see if I get hit. And some people are saying, look, I'm going to wait to get it before I travel, or because I have friends and family, and that's because they want to get it in the right window. They don't want to take it too early. Okay? But while they're planning this, they get sick. I'm not going to dwell on this, but it's phenomenal if I showed you the map. That your political party is dictating what you're doing for your health. I can't comprehend this. Can't comprehend this, but big difference. And I can show you the vaccination map, and it looks just like the election return. This is the scary thing. This is where people get their information. And I'm sorry, but that bar is blocking it. But this is vaccination hesitancy and refusal. And these are the sources that people are going to. The worst is the Children's Health Defense Organization. Go on that. That is a notorious anti-vaxxer site. So people are turning to them. And these sites are designed. In my world, there was an infamous site about having healthy pregnancy. A lot of young reproductive age women today, everything they do in life, it's like my medical student. This is the source of information. And they go to the site to get tips on having a healthy pregnancy. And it's telling them, don't get vaccinated. And it's hard to battle this. It's hard to battle this. Because there's no morals or filters. There's no editors. I can tell you, we're always seeking truth. It's not in the internet. So what does it mean for the future? Immune pressure means we'll have more variants, meaning the more people that get sick and now have immunity, and the more people who are vaccinated, we call this the immunity wall. Okay? Until you hit a certain point, and I think they use that horrible term herd immunity, remember that? That's veterinary. Serious, that's the herd. You'll have more virus being produced because people still will get sick. But in order for it to persist, it has to have a selective advantage. So it has to be more contagious, or it has to have the ability to avoid all this immune protection. And that's why you're always scared you're going to get some super evil virus coming out. There's some data now suggesting that we know animals get infected. We think that that's how Wuhan started, because of the wet markets in China. Unless you believe that it was an engineered military weapon, which believe me, I don't know, but and we know that the vaccine development, okay, that we're currently doing of highly variable spike glycoproteins, that's what we're focusing on, those spike proteins, will be insufficient. So we need better, newer vaccines. And there's 25 different labs working on it right now. To me, the holy grail is going to be finding the one that you can spray in your nose, because we need to get immunity on our airway. And that will keep the virus from entering our system. Plus, we're looking for what we call a pan-coronal vaccine, meaning it'll take care of many coronaviruses. So that'll give us a lot of bang for our buck.